Cushing syndrome. The clinical disorder resulting from prolonged exposure to circulating supraphysiological levels of glucocorticoid. Etiology. This is most easily thought of in terms of adrenocorticotrophic hormone, ACTH, dependent and ACTH-independent causes, Table 19. The term Cushing's disease refers exclusively to those cases arising as a consequence of ACTH-secreting corticotroph adenomas of the pituitary gland, as described in 1932 by Harvey Cushing, an American neurosurgeon. Clinical presentation. The clinical features of Cushing's syndrome have often been present for some time before the diagnosis is made. Patients may have been treated for individual components of the condition, e.g. obesity, hypertension, or diabetes before the penny drops and the diagnosis is considered. Women may present with oligamenorrhea and infertility, whilst children can exhibit isolated growth failure. Physical signs. Patients often exhibit many, if not all, of the classical signs of Cushing's syndrome, including moon-like facies and plethora, central, truncal, obesity, orange on matchsticks, prominent supraclavicular fat pads and buffalo hump, interscapular, acne, thin skin with easy bruising and purple striae, abdomen, thighs, hypertension, muscle wasting and proximal myopathy, hirsutism, due to excess adrenal androgen production in ACTH-dependent disease or adrenal carcinoma, kyphoscoliosis due to osteoporosis. Psychiatric features, e.g. emotional lability, depression, psychosis. It is worth noting that in cases arising as a consequence of ectopic ACTH secretion, the clinical picture is often modified with wasting, cachexia and pigmentation more prominent, the latter reflecting very high circulating levels of ACTH. Investigation. This should be approached in 2 stages. 1. Confirmation of the diagnosis. 2. Definition of the etiology. Confirming the diagnosis. Most centers use one or more of the following for screening purposes, with confirmation/further investigation of positive results. Estimation of 24-hour urinary free cortisol, UFC. Ideally at least 3 collections should be performed. Reference ranges vary between laboratories, but in general levels greater than 217 mol per 24 hours merit further investigation. Overnight dexamethasone suppression test. Pseudo-Cushing's syndrome. A disorder that mimics Cushing's syndrome, sometimes seen in the setting of excess alcohol consumption or severe endogenous depression, in which the overnight and low-dose dexamethasone suppression tests and UFC estimation can be abnormal. However, other indices, e.g. mean corpuscular volume, gamma-glutamyltransferase, may suggest the underlying cause, and the cortisol response to insulin-induced hypoglycemia is preserved, contrasting with the subnormal response typically seen in Cushing's syndrome. In addition, the low-dose dexamethasone suppression test, followed at its conclusion by a corticotrophin-releasing hormone, CRH, test, has been proposed as a means of discriminating pseudo-Cushing's from Cushing's disease. Cyclical Cushing's syndrome. A rare variant in which hypercortisolism occurs periodically. Serial UFC collections, timed to when the patient is symptomatic, may help to establish the diagnosis. All subsequent testing must be completed when the patient is in an active phase of the disease. Low-dose dexamethasone suppression test. Loss of diurnal cortisol variation. Measure cortisol at 9 a.m. and midnight. Normal midnight serum/plasma cortisol, asleep, is less than 100 mol/L, and in many instances less than 15 mol/L. For subjects who are awake, a higher cutoff is used, 200 mol/L. Alternatively, salivary cortisol measurement offers an excellent reflection of the plasma-free cortisol concentration and, due to the simple non-invasive collection procedure, can be conveniently performed at home. Defining the etiology. Once the diagnosis has been confirmed, tests are undertaken to establish the cause. Measurement of plasma ACTH distinguishes between ACTH-dependent and ACTH-independent causes. ACTH-dependent cause. If an ACTH-dependent cause is suspected, consider the following. 1. High-dose dexamethasone suppression test. 2. CRH test. 3. Selective venous sampling for ACTH, inferior petrosal sinus sampling, measuring ACTH before and after CRH stimulation, provides a sensitive and specific means of discriminating Cushing's disease from the ectopic ACTH syndrome. An ACTH ratio of greater than 2, pre-CRH, or greater than 3, post-CRH, between inferior petrosal and peripheral samples is indicative of a pituitary source of ACTH. Furthermore, an intersinus gradient, between left and right or vice versa, of greater than 1.4 aids lateralization of an adenoma within the pituitary fossa in approximately 2/3 of cases. For imaging, a MRI of the pituitary, an adenoma can be identified in approximately 60–65% of patients with Cushing's disease, but MRI findings must be interpreted with care, since corticotroph adenomas may be too small to be detected, whilst pituitary incidentalomas, which are not clinically significant, are increasingly reported, up to 10% of normal individuals. BCT/MRI of neck, chest, and abdomen. Although a good quality CXR may identify a bronchial carcinoma or carcinoid tumor as the source of ectopic ACTH production, in virtually all cases detailed cross-sectional imaging is required. See other, octreotide scintigraphy and positron emission tomography, PET, may help identify small tumors within the thorax or abdomen that are not visible with CT/MRI. 5. Urea and electrolytes. Unprovoked hypokalemia, i.e. in the absence of diuretics or other confounding factors, favors an ectopic source, reflecting the tendency for ACTH, and hence cortisol, levels to be higher in this setting. ACTH-independent cause. If an ACTH-independent cause is suspected, consider CT/MRI of the adrenal glands. Providing the patient is not receiving exogenous steroids, the main objective is to differentiate the possible adrenal causes, in particular adenoma and carcinoma. Treatment. Initial treatment should aim to reduce circulating cortisol levels using drugs that block steroid biosynthesis, e.g. metirapone or ketoconazole. Use of these agents should be restricted to clinicians with experience of dose titration and monitoring for adverse events, including rendering the patient hypoadrenal. Attention must also be paid to correcting hyperglycemia and hypertension. Thereafter, specific treatment is directed at the source of hypercortisolism. Pituitary adenoma. Transsphenoidal adenomectomy or hemihypophysectomy. Radiotherapy may be required where surgical removal is incomplete or in patients judged unsuitable for surgery. Ectopic ACTH, surgical resection of tumor where possible. Adrenal tumor. Surgical resection or debulking. For malignant tumors, adjunctive medical treatment is often necessary in the form of the adrenolitics agent 1-chloro-2, 2,2-dichlora, 1,4-chlorophenyl, ethylbenzene, mitotane, a derivative of the insecticide DDT, with or without systemic chemotherapy. Radiotherapy may also be useful in some instances. Exogenous corticosteroids, reduced dose or substitute steroid-sparing agents. NB. Bilateral adrenalectomy is reserved for those patients in whom the primary source cannot be localized or when conventional treatment measures have failed. In Cushing's disease, however, this can be complicated by expansion of the corticotroph adenoma, leading to enhanced ACTH secretion, pigmentation, and local problems due to tumor growth, so-called Nelson's syndrome. Pituitary irradiation may help to prevent/limit this. Prognosis. Untreated Cushing's syndrome is often fatal, predominantly as a consequence of the complications of sustained hypercortisolism, including hypertension, cardiovascular disease, and susceptibility to infection. However, with modern surgical techniques, benign pituitary and adrenal tumors can often be removed in their entirety, thereby curing the patient.